Hello, and welcome to Bite-Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Henoch-Schönlein Purpura, or HSP for short, under the section of Rheumatology. What is HSP? Well, it's the most common systemic vasculitis of childhood, and it's a type of small vessel vasculitis. As for its epidemiology, it affects about 20 per 100,000 of population, and as discussed earlier, it's most commonly seen among children, and that's about 75% of cases happening in those aged between 2 and 11. And it's most commonly occur during the winter and spring months. The etiology of HSP is unknown. We know that this is a small vessel IgA related vasculitis. However, the exact etiology is not really clear. It's usually a benign and self-limiting disease, and most patients will recover by about 2 months' time. 1/3 of patients will have symptoms for 2 weeks and 1/3 for about 4 weeks. And there is about 50% chance of the disease recurring again at another stage in life. In terms of its signs and symptoms, the most characteristic sign and symptom is the purpuric rash that occurs in about 95% of cases, and it covers classically the back of the legs, buttocks and arms. The important differential diagnosis to make in a question vignette would be differentiating it between meningococcal sepsis. It's quite rare for the HSP rash to be on the trunk or face. Patients could present with quite non-specific symptoms, and that's to say abdominal pain, vomiting, nausea, and even in some cases with hematemesis and melena. And these may precede the rash by about 2 weeks. The other commonly seen signs and symptoms in the case of a HSP is arthralgia or arthritis. That's happening in about half of the patients, followed by kidney involvement or nephritis, which is approximately about half of the patients. However, fortunately, only less than 5% of these cases will end up with chronic kidney disease. And best renal prognosis is seen in children who are younger than 7 years, and 3% of childhood cases will end up in end-stage renal disease. The GI manifestations and complications of the HSP is really quite rare. However, if they were to happen, and these are really quite varied, ranging from intussusception to appendicitis, pancreatitis, and even bowel perforation. As for the other investigation that you would want to carry out in a case that you're suspecting HSP, really is crucial to have a thorough history and examination. And after doing that and seeing that classic purpuric rash on the back of the legs and buttocks, really you should be thinking about HSP. However, it's also really important to be treating this as any other type of vasculitis, and that's to say asking for a urine dipstick to check for any evidence of hematuria or kidney involvement, suggesting nephritis, and also asking for bedside tests such as blood pressure, temperature. Moving on, you would be wanting to do some basic blood tests such as full blood count, renal function, liver function, and inflammatory markers. Again, thinking about treating this as a potential cause of vasculitis. And it's crucial to differentiate this with other infections and connective tissue diseases, and therefore if you're suspecting those, and for instance if it's not really a clear-cut case or history, it would be important to asking for those extra investigations and antibodies as appropriate depending on the case. In terms of the treatment, really there is no treatment proven to shorten the course of the disease, and you would mostly be treating just symptomatically, and that's to say that you would be using antipyretics and you would be using analgesia for joint pain. Steroids may be sometimes helpful for refractory cases, or if there is a case of persistent renal disease that doesn't resolve. It's really important that the care of this patient are joint with nephrology team, and that's to say that they would need close monitoring, especially in terms of the potential AKI, and the guidelines suggest that this monitoring needs to happen initially weekly. However, then you can drop it down to monthly urine test for up to 6 months. And in case this is quite a complex case that's complicated by GI manifestation and you would be worried about potential GI hemorrhage, then of course it would be important to admit the patient. Let's do some questions now. Which of the following is involved in the pathogenesis of HSP? 1. IgE, 2. ANA, 3. IgA, 4. rheumatoid factor, 5. ANCA. And if you recall, HSP, the exact etiology of it is not known. However, we do know that this is a type of small vessel vasculitis that is most likely due to IgA related disease. Question 2. A 7-year-old girl presents with 1 week history of worsening rash over her buttocks associated with bilateral knee and ankle pain. She has also noticed some abdominal pain, which started approximately 2 weeks ago. Her parents report she has been more irritable recently, but there isn't any complaint about headaches or fevers. On examination, you note a purpuric, non-blanching rash over her buttocks and backs of her thighs. There is no neck stiffness and she is apyrexial. The knee joints are both warm to touch and slightly swollen. Her GCS is 15. What is the most likely diagnosis? And the options that you get is 1. Kawasaki disease, 2. gastroenteritis, 3. psoriatic arthritis, 4. juvenile idiopathic arthritis, 5. Henoch-Schönlein Purpura or HSP. And if we go back to the case, you will realize that this is quite a classic explanation of HSP. You have got a young person who's presenting with a purpuric rash and bilateral joint pain and arthralgia. Vignette has also been kind enough to tell you that there isn't any neck stiffness, there isn't any fever, to help you not to be thinking about a potential bacterial or meningitis case. And as you recall, this is going to be classically associated with Henoch-Schönlein Purpura or HSP. Thanks for listening to this episode of Bite-sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.